Thank you to Danaher and to JC and Vanessa for the opportunity to speak to you all today about a different use case of AI from what we've heard today. But one morning, excuse me, I was really blown away by the future that we have before us and which we can all shape together in this room. So I'm going to start with a very brief video that's going to give you some insights into what we're trying to do at Virtue Foundation in terms of matching resource with need in low and middle income countries.
Virtue Foundation delivers clinical care and uses data science for good to impact global health and bring care to millions of people across the globe. What we're trying to do is continually refresh our foundational data set, how to create those mini knowledge graphs around each hospital, around each healthcare NGO. I think that is one of the most fundamental things that Databricks is assisting us with today. For the past 15 years, really under the vision of Dr. Ebi Elahi, who I co-lead the Actionable Data Initiative with, we have been focusing on building an AI platform for global health. By being able to understand the situation on the ground, where are the hospitals and healthcare NGOs? What is the work that they're actually doing? We're able to take that data and match it up to the clinicians who actually can deliver at that specialist level. There's currently 143 million patients every year waiting for surgery in low and middle income countries. It's a really large problem. But if you can create efficiencies in the data, you're talking about millions of lives. The Databricks Gen AI capabilities has allowed us to refresh our foundational data set. I personally do pediatric cardiac intensive care. I want to understand where are opportunities to take care of children and where could I be able to add skill, particularly in the care of complex patients post-operatively after cardiac surgery. Virtue Foundation's delighted to be a founding NGO for Databricks for Good. It's helping us to unlock data to bring impact at scale to millions of lives on the ground.
This gives you some insight into the work that we've been doing for the last 15 years, really. You can see the scale of the problem. There's 1.1 billion people living in multidimensional poverty, almost 3 billion years of DALYs, 3 billion per year of DALYs, and 143 million people every year in low and middle income countries who are not getting their surgery. And there are many people like me who travel to remote regions and deliver surgical and medical care. In the corner, you see of this map, you see a photo of Dr. Ebi Elahi operating in Mongolia. And really, the genesis of this project came from him. He's a very visionary person. And it was about 15 years ago, he said, this is crazy that we're all traveling all over the world like this. We should have access to this type of data in our laptop, in our office, in our home, so that we can more precisely target going to the right locations. And it started with the question, where should we go on our next surgical expedition? Well, that took us down a tremendous journey of AI and machine learning, and I'm going to share some of that with you now, of how we got there. His feeling was that global health philanthropy is a market. And when you start thinking about things from market dynamics, you start thinking about it very differently. But it's a lemon market. It's inefficient. There's asymmetry of information. The people who most need our care couldn't tell us. Here I am. And people like me, many are on the sidelines. Too many frictions to get involved. Where do I go? Is it safe? How do I get there? Who's going to take care of me on the ground? Is there a surgeon or a physician I'm going to be matched with? So we realized that it was inefficient. And if we could drive the data and the information flow, we could create more efficiency. And we started with this use case of trying to match people like ourselves to the right locations by specialty, subspecialty. But as we've gone along, we've seen these other tremendous use cases. Governments are asking us to help advise them because they don't have access to this type of data, even for their own countries in this geospatial format. Companies are interested in this data. Where are these patients, these unique patients? I go to the north of Ghana. Most people have a hemoglobin of 3, 4, 5. How? Why? How could we look at that? Imagine if you could look at a CBC for the patients in that area, which are done, and analyze them with AI. Like the possibilities are really mind-blowing. In terms of our initial use case, we were thinking about who are the players in that space. In addition to their countries themselves, there's large organizations, Gates Foundation, Gavi, doing really important work. It's slow, capital-intensive, high risk, but really important and necessary. But what can someone like me do? I'm busy, I have my practice, I'm taking care of patients in a cardiac ICU. I can be involved in short-term medical missions, where I can go for a week, 2 weeks, deliver care, treat 40 patients, 100 patients, 1,000 patients. There's a limit to the scale. It's the domain of the small. But if we could create this data platform and more efficiently match and bring more people like me to specific locations, suddenly it's meaningful, more meaningful in this sense of closer to one of these larger initiatives. So first we went and tried to find the data. We thought, this will be easy. We'll be able to find all the healthcare NGOs. We'll be able to find all the hospitals in low and middle income countries. And there must be some reference data. There isn't. We have special consultative status to the UN. It's really hard to find. So after several iterations of things through ArcGIS, working with Stephen Wolfram, working with Harvard's Geospatial Analytics, we had multiple iterations, but getting into about 5 years ago, the technology had caught up with the idea, and we could start to use machine learning, to use keyword scraping off the web to identify, is something a healthcare NGO or isn't it? Just from the web. And we trained those models, and we can now pull something and predict it and structure it. Similarly, we did the same for healthcare facilities. And we published that, the first for 24 low-income countries in Taylor and Francis in 2020, and then for 72 low and middle income countries in 2021. We translated that book into a platform, and I'm going to show you that platform later in the talk, but it has all the healthcare NGOs, the hospitals, the volunteer opportunities, and a 3D map that you can interact with to get into this data. But the reason why we aggregated that data source was to start to identify the medical deserts. So once you have this foundational data, we could couple it with other layers of data. Nightlight data, population density, doctor density, nurse density, road maps, you name it, you can couple it, and you can start seeing things. So this is just showing, for example, we took Ghana as a first use case, and then we developed the models to be able to go across all 72 countries. This is showing distance to hospital by speed. Dark red, you're far away. White, you're close by. But we look at it not just for everything, we look at it for every specialty. Neurosurgery, ophthalmology, cardiology, genetics. And then we put populations on top of it to be able to identify the medical deserts. This is just for general care, but I can show you all of this by specialty. Dark areas have coverage. The lighter areas and the more red of those lighter areas do not. Those are true medical deserts. Large populations of people live there, but they do not have care. We're also looking at estimations of disease burden using disparate data sources. So now you can understand the ecosystem of what the capabilities are of the hospitals and the healthcare NGOs. But now you want to be able to look across it by disease and understand that gap. And these are using multiple layers of data. Once we've identified these medical deserts and disease burden areas, we started looking about how do you reshape it? What are the things that you can do? So one, you could build a new hospital, right? That's one use case. Or you could add new care within the already existing hospitals. So we took the hospitals, We told the model, don't put a hospital on a mountain, don't put it in a lake, don't put it on a highway. Where are the locations where you could put this? And it was really tricky. We actually published this in 2 articles in IEEE of this methodology because it's multimodal. We're using image, geospatial, and numeric data all together to get to this answer. So the model tells us, and we did this work, anything in green, the darker the green, is a good place for a hospital. Well, we're not going to build it everywhere. So we said, tell us the top 20. And what's interesting, which is what we've seen across all these geographies, is that the medical deserts are really prevalent around capital, hub, large cities, primary, secondary cities, which kind of makes sense with what we're seeing in the world with migrations of people around these hubs, insufficient care, and real dramatic need of populations in those areas. There are others, as you can see from the map, locations that are important, but it was interesting the recursivity of this across geographies. And these are just a couple of use cases of how we've thought about reshaping the desert, in particular in Ghana. We've had a colleague who built this incredible hospital in Uganda, which for about $2 or $3 million stood up an ambulatory surgical center. Using solar power, because when we operate many times, my cell phone is out because there's a generator outage and you're in the middle of a procedure, you're stuck. So they tried to harness the sun, and they put a fiber optic cable in that would allow us to sit in our hospitals in New York or Boston in real time, be able to be in a case. We've had retired gastroenterologists who are doing GI procedures in that hospital and surgeons who are remotely assisting the fiber optics so there's no delay. So it's really interesting to see how technology is opening up a huge vista of opportunities. But he put this in a location without a lot of information because our technology hadn't existed when he first built this. And now we're looking at this in Ghana and saying, if we put an ambulatory surgical center, we can tell you where to put it. And guess what? We're going to put a solar layer in, and we're going to put the energy layer grid in, and we're going to tell you where is optimal based on getting your fiber optic cable in the most efficiently and cheaply and harnessing the sun's power to its maximum. Once you do that, you can rerun the models and start thinking, now what's my desert look like? Similarly, tricycle ambulances, the road networks are terrible. They're dirt. We can use weather maps to analyze when they're going to be washed out. 60% of the rides are mothers who are delivering, so maternal mortality, infant mortality is all impacted by access in these medical deserts. And this we did in partnership with Moving Health from MIT. We've built these ambulances, created a local business, and we brought CAD, all this technology from MIT where they have learned how to use it and build these ambulances for themselves in partnership with both our organizations. But this is true reshaping of the medical desert based on the data. And this is just showing some of the maps we developed for the ambulance use. This work we are building now at enterprise grade. I think someone else, or 2 or 3 people mentioned this democratization of the tech stack that's happening. I think it's really important because it's making it such that we can build these capabilities not at academic levels anymore, but true enterprise grade. And we are building this as if we were, Bank of America, P&G, or Danaher, that it's a true enterprise platform. And I want to talk about how we're scaling this now through generative AI. So we have this foundational data set plus all of the insights that we've derived. But how do you keep refreshing it? The manual part of this is really intense. But Gen AI opened up incredible opportunities. And I'll give you the example of how we're ahead of the science. We were talking with some of our data partners and some of the companies we're working with. And I was like, I'm deep in the weeds of this data set 4 years ago. I was like, we need to link which hospitals work with which healthcare NGOs. And they're like, it's not possible. I was like, I can see it with my own eyes, so I'm telling you it's possible. It's like, well, maybe if you could make us a spreadsheet and you could pull some keywords in sentences, or chunks, and you could match it to the other piece of the sentence, the keyword of the chunk, and put a column that says yes or no. This tells you this predicts this, or this doesn't predict this. We'll try. So we were doing Gen AI before Gen AI, but we didn't know it was Gen AI. But we were able to link which healthcare facilities were working with which healthcare NGOs in the original data set. So now we're doing this at scale with this lens over the net to be able to continually refresh this foundational data set. For our use cases, as I mentioned, the volunteers, the governments, and the insights that I think are really important for all of us in this room as we think about bringing care to these sorts of markets. And I think I'd encourage everybody here to be thinking about how can you think about diagnostics differently in terms of getting access to these locations. This is showing us just the use case where we're scanning all the PubMed articles that are associated with a healthcare NGO or a hospital, all of the Reuters news articles, any blog posts that a medical student wrote, you name it, with any images, any video, we've tagged it, and we refresh our structured data, but we leave the unstructured data for future if we want to continue to structure out of it, or we've also built a RAG over it where you can interface with the data and chat with it. Because that's what I want to do. I want to answer the questions I want to ask on the data that exists. We're doing the same with visual AI. This is showing a photo from a hospital in Ghana, and it's amazing. I know you can't see it very well, but from this picture, which when I walk into a hospital, I understand its capabilities and capacities. But the AI does too. It tells me that this has an ultrasound machine. It tells me that it has surgery and a blood bank. It tells me that it has obstetrics and gynecology. Can you imagine just from this? And it also can tell me where this hospital is located. It's now trained to a point where it sees a picture and says, that one's in Ghana and that one's in Tanzania. It's incredible what it's capable of starting to tell us and the information that it's able to extract. And for that data, as I said to you, we're putting it into what I call mini knowledge graphs around each location. So we have this for every hospital, every healthcare NGO. What are the specialties, the subspecialties, the capabilities, as much as we know them. And then in partnership with governments, where we have relationships, we're also deepening the data and looking at this further. And with companies, thinking about what data sets might align and be interesting to think about problems differently. I said I would finish with showing you our current iteration of the platform. I just show it to you so you get a sense. We haven't had a full product launch. It's just out there. It's interesting to see how much traction it's gained. But we wanted to finish the full enterprise architecture and Gen AI extractions before we launch it, which we will be doing later in 2025. But we tried to be able to move between grid and globe, so you can see this data like you would Airbnb. You can flip it and see it in 3D in a globe. And using H3, you can zoom down in, so the data keeps reloading and refreshing all the way down to street level. And I'm just going to walk through just sort of how you would get on it from the web, and hopefully it'll track. So if I'm a volunteer physician, I'm looking in pediatrics. I can look in a region like Africa or Asia or a specific country. I'm going to click on Ghana, and I'm going to see what kind of opportunities are there right now where they would like me to volunteer in Ghana. What are the NGOs? Where are the hospitals doing pediatric care that would like to have someone of my skill set? I can look at that a little more broadly than just Ghana, and I can start to put in a little more information about me. I'm a doctor. I'd like to go someplace where I can speak Spanish. I can see how risky am I willing to go in terms of location. I can customize it, and it can come up with these opportunities that might be of use of interest to me, and I could really bring my skills to treat these patients and upskill the local providers who have the capacity to take my knowledge transfer. Now we can switch this over to a globe mode and see those volunteer opportunities. We can see the healthcare facilities. And then we can start to drill down in and start loading some of those visuals that I was showing you in terms of medical deserts and travel times to facilities. So this is looking at more specialized care. You see how different, this is more general care. So you can see the areas that are light. There is sort of general health care. The darker red areas, it's very hard to get access to it. But now we start to look at, if you actually arrive there, what capabilities are there? So you can see visually these medical deserts. And then you can start to think a little bit more about, where do I target where I go? Where do I target as a physician who wants to volunteer? Where would Danaher target if it wants to think about diagnostics for a particular area? You know, where would a country decide where it's going to have its next dental clinic? This becomes really important information, I think, for all of us. And this is going from the map into another opportunity where you can start looking at the specific hospitals and dive more deeply in. So as I mentioned, we have about 30,000 hits per month already. We're a reference source for Perplexity and others. So I feel like we've really come to fruition if we've become a reference source in the LLMs. And I really wanted to finish with how the DBS system and the VF system can align in many ways, and I thought that's important for this audience. But we're trying to create an efficient market, and that it requires us to be in this continual loop. The data quality. We have been on a journey of data quality, as I know everybody else has here. But you're only as good as the data, and the tools that are, are out there are allowing us to get better and better at quality data. With that, the insight quality enhances. And that's not enough unless you also have the platform quality. That's why I say I hesitate to show you it in its current iteration, because it'll blow you away in 2025. But it's that continual loop. It's really important to create this really efficient market, right? We'll have more efficiency because I will know where to go. It's going to be more quality care because I will be treating the right patients and I will be partnered with the right physician. It'll reduce waste. I'm not wasting my time going to the wrong location. I'm not spending money going someplace where I could only see 10 patients when I could have seen 100. And it'll increase engagement because the friction's down. I can see better what I'm going to do, with whom, how. I can visualize it. This is our Core Actionable Data Initiative team, and I really want to thank. This is a Herculean effort that's not just mine or Dr. Elahi's. And to finish, to say that we're publishing our third book, which will be out in August of 2025, which is more the thinking behind this work as opposed to the data. This is really the vision of what we're trying to build. And if you want more information, my email, the QR code will take you to our website, and you can get to VFMatch and other things from there. And none of this work would really happen without partnership. And we're really grateful for the partnership of Danaher Foundation, and particular J.C. Gutierrez Ramos for his own personal support, and for Michael Chambers from the Danaher ecosystem for also supporting this. We really could not have built what you've seen today without those sort of connections and support. Thank you. Oh, thanks. Can't get rid of the cough. Thank you.
Wow, you have so much to be proud of. That was just amazing.
Thank you.
I know it's not technical, but I would love for you to share with us how you got started on this journey.
Oh, yeah. Well, I think I alluded to it, and I really do want to give all the credit to Dr. Ebi Elahi for that vision. Like, who in 2009 was traveling in low and middle income countries doing this work and was saying, we're going to use AI and machine learning to make all of this visible? Even I was like, how are we going to do that? So, and then we ended up with those sort of issues that I talked about. It has to start with the data. But it was really visionary, because if we hadn't started that work from then, I don't think we could be as sophisticated in our thinking now, because we've been deep in the weeds of the messy data for really 15 years. And there was a clear need of how do you optimize those connections.
For the audience who lives with the challenges of AI and the technical challenges every day, can you elaborate on some of the specific challenges in this pioneering work that you faced and how you overcame those?
Yeah, thanks for that. Again, I would go back to the data. The first was finding it. And we all struggle with finding data, but it's even more difficult when you're trying to do it in a low and middle income country setting, where there's less human collection of data. You know, if I go into the operating room in Tumu District Hospital, there's a nurse who writes in chalk on the board each of the procedures. Another one's done, erases it, and puts it up again. And you think, if somebody walks by, that's the data for that month gone, right? So those are the types of data that you can be dealing with. And national data from the countries also are a struggle, because they're relying on regional and district health ministers to collect that data from these hospitals. And we really walk through, how do you think about this flow of information? How do you think about this? And we started with Ghana as a use case, test case, and Mongolia as well, because we've worked there for 15 years, because we could see if things, do they pass a smell test? This is what we're getting out of our analytics. This is what we see with our eyes. These are the beginning phases of this kind of work. It was very, very challenging. And then I think when we've moved to creating this foundational data set, this ability to extract things now in real time in a way that we couldn't. And Dr. Lahiza really had this view of, I would get very stressed in the beginning. I was like, we don't have data in this region. He's like, that's data. Lack of data is data. Why don't they have it? Like, this will shine a spotlight. Eventually, we'll get the data. And also taking the data that humans generate just by existing. There's a lot of that. There's no ability for someone to manipulate it. We're trying to increasingly utilize and access those data sources, of which there are many more available that are geotagged, that can align with what we already have.
I'm going to allow audience members to ask some questions in just a moment, so get your questions ready. I'll just ask one more. I'm a believer in partnership.
Yes.
So I would love to hear about how partnering has helped enable what we heard about today.
It's been an incredible part of our ability to scale. Really, really important to this work. I think that being able to partner with our data science companies, particularly as that becomes more routine, and these partnerships, some of them go back to, in Carto, there were 3 people in the company. It's now, a massive company, hundreds of millions of dollars, mega companies. We grew up with them. Data Robot, incredible work and partnership together using automated machine learning that we could scale faster. Databricks, similarly, that's helping us build our data pipelines. And these were true partnerships. We were founding NGO partners to all these organizations, where they gave us their software and their data scientists to work with our internal data scientists for free. So those partnerships were critical. And Danaher, honestly, JC is one of the most visionary human beings. And I'm so grateful to the foundation here of Danaher and what that's meant in that partnership of helping us in bringing this to the level that it's at now And I would love to think about ways in which we could use this to think about getting the diagnostics, the therapeutics, to the locations of the people who really need them. And also, I think we talked about with trials today and thinking about the biology. There's so much untapped thinking around these markets that I think is really, really critical to the patients. And you may find that that actually informs our own healthcare here. I know that myself, as I travel and work across the globe, it changes how I think about the patients I care for, how I care for them, what I do in new ways that I wouldn't have predicted.
Yeah, I think it's inspiring that the first real world high impact discussion we've had today about the AI is one that's in low and middle income countries.
Yeah.
It's amazing. Well, let me go to the audience now. I'm sure there's some questions. All right. Well, we'll go to Vanessa and then JC.
Thank you, Joan.
Thanks.
Such an inspiring presentation. Thank you so much for the hard work that the whole team has done for a very good cause. As we were coming from the panel where we were discussing access, right? I'm wondering, what were the specific changes that you had to implement in these hospitals for them to be able to record the data that you ultimately use in your softwares? I'm wondering whether there was a need to do significant change in the healthcare system, or how were you able to actually access the data?
I think at this moment in time, excuse me, we are collecting from some of the aggregate country level data. We're also doing a lot of work in terms of trying to impute what we think the burdens are of disease in these areas to try to understand. I think eventually, at the moment, I don't want to confuse this, that we have data from every single hospital in terms of every single patient. We are extracting the information that's available and known about those hospitals, and then we're taking what's known about diseases, and then we are creating those maps on top of it. It's not to a level yet where we can get specific data from every single hospital. We've looked at lots of different ways of looking at this. We've partnered with Dun & Bradstreet, looking at flow of commercial data. We're looking at all of this, Vanessa, to try to see how do you get more and more granular. Where we are doing specific projects, we have sensors for collecting data. So we're really looking deeply at that part of the problem.
Thank you, Joan. Just to be specific on that, obviously, in your journey, I think it would be good to the audience to see in those hospitals where you have the granularity, what is the level of granularity? Meaning, do you know what? Can they perform a CBC? Do they have a machine? Do they have a scanner? Is the scanner broken? Would you share some of this experience in terms of the granularity that you will eventually generate?
Yes, and that is the type of granularity, JC, that we're trying to work towards. It's not straightforward and it's not easy, but that's where I think some of this image analysis is really helping us in the Gen AI capabilities, because it gives you the ability to extract things without humans getting involved. So we're trying to use that to understand increasing levels of granularity within these healthcare facilities. It's a challenge. I'm not going to say it isn't. Every hospital I've been to, it's a challenge to get the humans to collect it. That's where some of the visual stuff is very, very helpful. Every hospital has a cupboard of junk. It is really wonderful, high-tech diagnostic or imaging equipment that it broke and there's no biomedical engineer, or there's one piece or part, or there is a supply chain issue because you need to buy one thing to make that machine work, and once it runs out, nobody replaces it. So I think if we could think through together some of those things, the supply chain issues, the maintenance issues, the biomedical engineering issues, because we work and we bring biomedical engineers with us. We're looking for that on the platform too. These are all really important problems to solve. And I just think with time and the continued refinement and the kind of work we're doing and the partnerships where you may have data that would really interface well with this and we could start to do different things. Because I think if Coca-Cola can manage to know where every single one of its Coke cans go and if it's bought or sold, we should be able to do this collectively for the diagnostics and therapeutics for patients in these markets.
Okay, we have one more question.
Thank you so much. Really inspiring. And in the time you started talking, my mother, a retired physician, is already on the match.
Oh, great.
Looking for opportunities.
Oh, great.
So you a little bit answered this already, but maybe I can still ask it. You know, I lived in Ghana for some time, and so I couldn't help but notice that on the map, one of the large, medical deserts corresponds to a national park, something I know because I live there. Mm-hmm. And I was wondering, in a lot of these communities, there's a huge number of people that are online and probably surprisingly online.
Yes.
With a lot of local knowledge.
Yes.
So reinforcement learning human feedback, RLHF, was such a incredibly successful sort of iterative training loop for ChatGPT and so many other things. Yep. Do you have ideas for how to tap into that data source?
Yes. We've had ideas for that for like the last decade. I mean, we worked with the Billion Prices project from MIT. I don't know if some of you are aware of it, where they could think about the market basket to measure inflation by having someone collect a basket of goods. We've been thinking about those ways to tap into the local community exactly to augment this data set from here. It's a really important part of the growth phase of this because everybody has a cell phone. And I think that's also what's nice is this is publicly available to everybody who lives everywhere. And you'd be surprised to how many physicians come to this platform that aren't necessarily, it's doctors in the US, it's the West. It's not. It is a lot of US physicians, but we're also seeing a lot of traction from around the globe. And even when we travel ourselves and work in low and middle income countries, lots of doctors from the capital cities. In Ghana and Accra, they're traveling up to Tumu and Wa in the Upper West and doing GYN surgeries up there. They're learning a lot and coming back and starting to change things within their country. Same in Mongolia, in the capital, Ulaanbaatar. For 15 years, we've been taking ophthalmologists out to the western border. We've developed the retina service, the cornea service, the glaucoma service. We've developed ophthalmology across the entire country of Mongolia by this continual coming of us and in partnership with some other NGOs that come across the year so that there's a continual flow. I mean, it's incredible how you can then harness this combined work over time using the data and coupling it up.
Well, thank you for sharing with us today, Joan. And I'm on behalf of Danaher, I think we're just honored to be involved at all in your work and wish you the best of continued success.
Thank you. You've been a great partner. Thank you.